Hello, everyone, and welcome to today's Ask the Endos. I'm Dr. Steve Edelman, and this is my very good friend and colleague, Tricia Santos. We're both endocrinologists. We both work at UCSD, and I got to know Tricia when she was about this big doing her training.
I've been going since then.
At UCSD. And we're excited today to take any and all questions about your type 2 diabetes or type 2 diabetes of someone you love. It's important to say this up front. We're not your doctor, and we can't give you specific advice about your own personal care. But if you call 858-671-2151, you can make an appointment. The waiting list is only 6 months. But we will answer the questions as fully as we can, and we appreciate all the questions that have been sent to us already. Trish, say something magnanimous.
Hi, everyone. Well, thanks for having me, Steve. I always love doing these sessions, and I'm excited to be here and talk about type 2 diabetes.
Okay.
So we have a lot of questions, so let's get started. Let's jump right in.
We're going to answer as many.
Yes. Okay. This first one I want to start with because I think it's a great overall umbrella question for type 2 diabetes. And it says, why has my glucose baseline increased after having type 2 for a while? And I'm not exactly sure what they mean by glucose base increase, but what I think they mean is sometimes I think it's just important to talk about type 2 diabetes as a disease and kind of what it is and what happens over the long term, right? So for all of those of you with type 2 diabetes, this is not your fault. We talk about that a lot. Type 2 diabetes is a genetic disease. And I think it's just really important to know that even if you're doing everything right with type 2 diabetes, it is a progressive disease and it progresses at different rates for different people. Some people, they just kind of flatline and it stays, it's a very long and slow progression. Some people, it just kind of is more steady and it progresses. And that can be really frustrating because you could be doing everything right. And yet, your glucose levels could be creeping up even though you're taking your medication.
Yeah, you're absolutely right, Tricia. There's a phrase we use in the doctor meetings, the natural history of type 2 diabetes, because when you first get diabetes, your pancreas may secrete a ton of insulin. It may not work that well, which is why you have diabetes. But over time, you lose that insulin secretory ability and your therapy may change over time. It's not your fault. And that's why it's very typical that your doctor may add medications to your current regimen, not take them away and exchange. Typically it's adding, and it can be frustrating. So that's important. Your diabetes may change over time. It's different for folks with type 1. In a way, you get type 1, your pancreas is destroyed by these autoantibodies, and your diabetes stays pretty much the same. So there is no true natural history of type 1 like there is for type 2.
And I love what you said about adding medication because I really do think that's a hot tip. I can't tell you how many patients I see. I see a lot of new patients every day because I work in the hospital, new to me. And all the time I see people and I say, why aren't you on Metformin? Or why aren't you on, one of these GLP medications? And they'll say, oh, my doctor stopped that when I started insulin. And it really is important to kind of add on medications instead of just switching to something else. Now, there may be another reason why they stop them every now and then. It could have to do with kidney function or something else. But in general, you do want to add medications rather than switch over.
Yeah, these medications work in different ways. And so with different mechanisms working together, then that helps bring down the blood sugars. And, Dr. Pettis is calling me. He doesn't even know I'm doing a program. He's the type 1 guy. So, okay.
All right. Oblivious to all things type 2.
Yeah.
Okay. All right. Here's another question. And I think this is a common one. Can you talk about the differences between Ozempic and Mounjaro? So Ozempic and Mounjaro are both GLP-1 medications. We talk about these all the time at TCOYD. But I think it is a little bit confusing to patients to know, we send the message how great they are. These medications have a lot of benefits and we think almost everybody should be on them. But is there a difference between them? We have Ozempic, Mounjaro, Trulicity, just to name a few. Those are some of the most common ones.
Yeah.
Victoza. Yeah.
But then we also have, add to the confusion, when these drugs that Tricia just mentioned get the official indication for weight loss, the FDA makes them give a new name, even though it's the exact same molecule. So I know Eric prepared some graphics that he can throw up, but if we go to the old GLP-1, Victoza, and Victoza is a once daily GLP-1. They're not quite as strong as the ones that just came out in the last couple of years. And if you use it for obesity, then it's called Saxenda. Then you get to Trulicity, and Trulicity doesn't have a second name, but Trulicity is a once weekly GLP-1 that Lilly makes. Then they progress to Mounjaro, which is actually not exactly the same as the GLP-1 alone. It's a GLP-1 and GIP. If we told you what that was, you get dizzy. Glucoregulatory insulinotropic polypeptide. I told you.
Wow, I'm impressed.
And it's got the indication for obesity as well, and that's called Zepbound. And I'm going to let you do the Ozempic ones, but I want to finish the Mounjaro Zepbound. And then Zepbound recently did a study looking at people with obstructive sleep apnea. So it got the indication for obstructive sleep apnea, which is pretty common in people with type 2, but anybody can get it. And so the indication is under the Zepbound label, not the Mounjaro label. So I think in general, you have to remember that these drugs are the same. And when they study them in other medical conditions, they may have to call it a different name.
Yeah, exactly. And I think you were saying Ozempic. So Ozempic, the medication for weight loss, that's the same exact medication as Ozempic, is Wegovy. So again, it gets really confusing. I think the short story is all of them are great. And if you have a choice, oftentimes when I'm prescribing these medications, it's whatever one's covered by insurance, honestly.
Yeah.
Now, there are some nuances between them while we may pick one or the other. But in general, if you can get on one of these medications, I would say being on one is better than, not being on one at all. Another thing that you have to keep in mind is that these differences that Steve was talking about in terms of one of them may be approved for helping heart disease, and another one may be approved for obesity, and another one for sleep apnea. Knowing these indications can actually help you advocate for yourself to talk to your doctor about prescribing them for a certain reason. Because if your doctor links it to that particular diagnosis, it may actually get paid for by your insurance. Whereas if they don't, they may say, oh, it's not covered, but they just didn't choose the right diagnosis.
Yeah,
so it's tricky.
That is so true. So I have a patient with type 1. He had sleep apnea, and his doctor got him Zepbound for the specific indication of sleep apnea. His wife was about to leave him, snoring loudly at night. And I'm serious about that. And so I think it's a good time to quickly, and then we'll get into the more questions, all the other indications for these two drugs, because this is so important. And as you've may or may not know, the indications go far beyond glucose control, weight loss, and even far beyond cardiovascular benefits. So with Ozempic or Wegovy, same exact drug, there is an indication to reduce the progression of kidney disease, and just recently to treat what we call fatty liver or MASH. And we'll talk about that more later. I think I saw a question about that.
Yeah.
And that's such an important issue, I think. And then we got the obstructive sleep apnea. So I think we got all the other indications, and there will be more.
I mean, these drugs should be put in the water, if you ask me. They are that good. There's studies that are coming out now. They're not approved for this yet, but that they may be helpful with other addiction disorders. So not just, maybe related to food, but drugs, alcohol, other things.
There's vodka in this glass. So
get some Ozempic. So yeah, I think the benefits far outweigh the risks. And I do, there is a question in here that kind of relates to this, which says, my numbers don't go lower than 149. 149 is pretty good. But they're as high as 240s after eating. And their doctor wants them to take Ozempic, but they're scared of taking it. And I think this kind of moves nicely into the next section of this. And I think, I always tell patients, if you went in your medicine cabinet and you looked at your Tylenol bottle or your Advil bottle, I mean, you would be scared you were going to die tomorrow. It is, anytime you go
Aspirin,
aspirin, any of those, anytime you go reading the safety labels, it can get really scary. But every medication that we take is really always a balance of what are the benefits and what are the risks.
Yeah.
And with these GLP-1s, like Steve was talking about, weight loss, blood sugar control, sleep apnea, heart disease, kidney disease. I mean, the benefits go on and on and on. And they almost always, in the patients that I see, the benefits are way up here and the risks are way down here.
Do we look like we have honest faces? We truly believe that these drugs have changed the way we treat type 2 diabetes. I'll just say two other things. The very first GLP-1 called Byetta was approved over 10 years ago. And a drug really proves its safety record once it's out in the open market for a couple years. So this is over 10 years, 2006.
No, yeah, almost 20 years.
Almost 20 years. Gosh.
Steve, brush up on your math.
These drugs don't help with math. And the other thing I want to mention is GLP-1 is a natural hormone. People with type 2 diabetes don't have enough.
Yeah.
And this drug,
all of you have GLP-1 in your body.
Yep.
Yeah.
And so don't be afraid. I think that when I tell patients, when they look at all their medications, their blood pressure, their cholesterol, this is one medication you do not want to stop and you want to get. And it's changed the life of so many people. 10-second story. My electrician came over this morning to do some work and he looked like a new man, and he was put on Ozempic and he looked great. He feels great. His doctor stopped the Metformin. His blood glucoses went up a little too high and he's restarting it. So it's funny you say that, but it is impressive. And especially since it's so easy to gain weight through the years. And we're going to talk about this, but weight is the underpinning of what we call the metabolic syndrome, which can lead to many other medical problems, heart, kidney, and liver.
Yeah. Okay. On the note of possible side effects to the GLP-1s, there's a question here about pancreatitis due to GLP-1 and someone saying that they had pancreatitis that was due to a GLP-1. Now, I want to address this because you do hear about this with pancreatitis and these medications. The reality is when you look at the studies that they've done with these medications, the risk of having pancreatitis, which is inflammation of the pancreas, on these GLP-1 medications is actually very, very, very low. Sometimes it's even hard to prove that it was the GLP-1 that actually caused it, right? Pancreatitis is a tricky diagnosis sometimes regardless.
Yeah.
I don't know what your thoughts are, Steve, but I would say, for those of you who have never had any pancreatitis or pancreatic disease, the risk of going on these medications is very, very low, almost nothing. And sometimes we avoid these medications for people that have had recurrent, bouts of pancreatitis. To be honest with you, I'm not even sure that's because I'm worried about the medication. It's more because people are just going to keep taking you off of it, So there may be some reasons where you can't take it if that's the case. But if you have never had any pancreatic disease, the risk is exceedingly low.
Right. Where'd you do your fellowship?
I learned from the best.
I could not add one thing to that. I wouldn't let that stop you unless you're prone to pancreatitis. And, I always say to the doctors who are considering using these drugs in someone with maybe high triglycerides, which can also cause pancreatitis. So it's always important to look at the cause of pancreatitis before you decide yay or nay.
Yeah.
And this is a drug that you want to look for reasons to take it, not look for reasons not to take it.
Yeah, that's a really good point. Absolutely. Okay. This is a really common question for people with type 2 diabetes. It says, I'm only on metformin and my sugar has been going up through the years. I wonder what medication could be added to my regimen to help this. And I think, historically, metformin was the first medication we used to use for people with type 2 diabetes. And many providers are still practicing that way. You get type 2 diabetes, you start metformin. Metformin's a great drug. It's very safe. It works well. It doesn't cost a lot. But these days we don't necessarily start with metformin anymore, just because we have these GLP-1s and the SGLT2s, which you've heard a lot about at TCOYD as well. So what do you think, Steve? But what I'd like to say is we still see a lot of patients who are still on metformin and need something else. It's very common.
Well, I would say that the vast majority of doctors still use metformin as first-line therapy. It's easy. It's a pill. As you said, it's safe. It's inexpensive. It doesn't get turned down by insurance companies. And if the control is not good, typically we add to metformin. Now, if you have a side effect from metformin, like maybe diarrhea or something, then obviously we'd switch. But we have lots of choices now.
Yeah.
And as Tricia knows quite well, the American Diabetes Association and other diabetes organizations put out guidelines for doctors of what to use depending on the characteristics of the person with diabetes. So Tricia mentioned SGLT2 inhibitors like Jardiance, Farxiga, Invokana, Zynquista, and these are a class of medications that have been particularly effective against preventing congestive heart failure. The indication, of course, is glucose control, but why not get the secondary benefits of reducing heart disease and kidney disease?
Mm-hmm.
And if someone's had a heart attack or stroke, or maybe even MASH, which is fatty liver, or chronic kidney disease as well, you might consider a GLP-1. And there are other choices, but I think these are the most obvious ones that have the most benefits. What else would you think is available?
I agree. I think those two I would go for first no matter what. And that's only because why not get an added benefit on top of controlling the diabetes, right? After that, it kind of depends on how high your A1C is and kind of how far you have to go. So if you don't need a whole lot of extra help, the DPP-4 inhibitors are pretty good. Like Januvia. Tradjenta. Those medications are great because they're very safe and very easy to take. If your A1C is really high, then insulin is a great option. I think there's a lot of kind of stigma and fear around insulin. And to be honest, it's one of the, second line medications that we use for type 2 diabetes because it works so well.
Yeah. And the initial experience with insulin might be one shot of basal insulin a day. Every type 2 is eligible for a CGM. It helps you titrate the dose to bring your morning blood sugar down. And it could really lower your A1C from a fairly high level down to the 7% range. Now, the other thing is I've had patients with very high A1Cs where you might be considering insulin in the past. You go on a GLP-1 and, oh my gosh, everything comes down.
Yeah.
The A1C, their weight, their blood pressure, their cholesterol levels. So you'd be surprised that when you get one of these medications and you're very adherent with it, you can really improve your A1C greatly. Now, you didn't mention sulfonylureas because they're out there.
Yeah, they are. Sulfonylureas, Actos or pioglitazone is out there. These are older medications that we have to treat type 2 diabetes. I still see quite a few people on them, to be honest, mostly because they're inexpensive and they work really well. Now, these two types of medications, the TZDs, which is Actos, pioglitazone, and the sulfonylureas like glipizide, glyburide, those medications, like I said, they work really well. They just don't have any of the other benefits. Well, Actos has some benefits. It may have a little bit of benefit with some heart disease and with MASH, but in general, they're not as beneficial as the others. So we kind of reserve them for, people who may not be able to be on other medications for another reason.
Yeah, and so the sulfonylureas like glyburide, they can cause weight gain and they can cause hypoglycemia, low blood sugar, and all the other medications we spoke about do not cause low blood sugar. And we know that low blood sugar is no fun, but some people need to take it because they're paying for their medications out of their pocket, and they can be used safely. So don't panic if you're on it.
For sure. You mentioned CGM, Steve. So CGM or continuous glucose monitors. I think most of the type 2s are aware of what these are now. We've been using them in all of our patients with type 1 for many, many years. And now they're really becoming standard of care and common in type 2. There's a question here asking, how do I get a CGM if it's not covered by my insurance? And because this patient here is not on insulin. And that is a common problem. I think the insurance companies are getting better, I would say. There are some commercial insurance companies that will cover CGM without insulin, though it's very
Really?
rare. It's very rare. So,
If your dad is the CEO of
yeah.
a company, you might be able to get it.
But what do you tell your patients, Steve, if they want a CGM and they're not on insulin?
Well, I should just say one thing ahead of that is that there have been over 300 studies looking at CGM and type 2 diabetes. Many of those studies in people with type 2 and not on insulin, and they all show collectively the same benefits. A1C comes down, and patient reported outcomes, meaning people just feel better on it. They know what's going on. They're more adherent with their medications. It helps them exercise and eat properly. So there's a ton of benefits. Well, one, you can buy them over the counter.
Mhm.
There's the Stello, which is made by Dexcom, and then the Lingo, which is made by Abbott. And they're probably about $30 or $40 each.
I think so, which, to be honest, is about the same price as the prescription. So those two that Steve just mentioned, you can get without a prescription. You can just go to the pharmacy and buy them. The prescription ones, the Dexcom and the Freestyle Libre, Eversense, those need a prescription. But the Dexcom and the Libre are about $75 for a month supply, which is essentially 35 or so per sensor.
Yeah. So are you saying that, and I think I know what you're saying, and I agree with you, is that I'd rather just ask your doctor for a prescription and get the G7 or the Libre.
Yeah.
Because they come with better features on it.
Yeah.
And I agree with you. Now, the other thing is, and if your glucose is not under good control and your morning blood sugars are high, you could ask your doctor if he could give you a little bit of basal insulin at night to bring down your morning blood sugar. And he might pass out because no one ever asks their doctor if they can start insulin. So once you start that basal insulin, you are eligible for a CGM. And that's my little trick.
Yeah. I use that trick too in the hospital. So I see a lot of patients who have had kidney and liver and heart and lung transplants. And oftentimes these patients need really good glucose control when they leave the hospital, but sometimes they just need a pill. And so we'll give them a correction scale insulin where they only use it if their blood sugar is really high. And most of the time they don't need it, but then their CGM can get covered. So.
Yeah, that's a very good, it's not really a trick, but it's.
I mean, it's necessary, and we're doing what's best for the patient, which is.
Yeah. So let them sue us.
All right. Well, let's stay on the topic of technology. There are a couple of questions here about insulin pumps for people with type 2 diabetes. I guess I'll start off by saying, maybe just describing what an insulin pump is, and then maybe Steve, you can tell us about pumps in type 2.
Okay.
So for those of you who don't know, an insulin pump, I think sometimes people think that the insulin pump is this magic device that takes care of everything for you. We're getting there. It's not quite there yet, but we're getting there. So an insulin pump is basically a device that holds insulin in some capacity. And there's different kind of ways to wear them. Some of them are kind of right on your body. Some of them have a little insertion area where, it's connected to tubing and things. But essentially the pump holds some insulin. It delivers what would be a basal insulin. It trickles out a tiny bit of insulin all day long. And then it gives additional insulin when you eat food or when your blood sugar's high. Most of the time that's patient directed, meaning the patient's kind of telling the pump how much they're eating or, sometimes how high their blood sugar is. Now, the latest insulin pumps, we call them AID systems, automated insulin delivery systems. They talk to the continuous glucose monitors. And the reason that's important is they can do a little bit of the work for you. So they can, if your blood sugar is running high, they can give you more insulin. If your blood sugar is going to drop low overnight, it can give you less insulin or even hold the insulin for a little while. So there are some benefits to these devices, but what do you think about using them in type 2, Steve?
Oh, absolutely. They're way smarter than you when you're deciding
and
the
then
insulin
us.
dose. And us. I mean, it's the standard of care for people with type 1. And as you said, the CGM communicates with a pump, gives insulin when you need it, and turns it off when you don't need it. And these continuous glucose monitors can predict can predict your glucose in the future up to an hour or even more. And when they first came out, they said, oh, they're just for type 1s. So why should someone with type 2 diabetes have to make their own decisions? And we call those dumb pumps. That's our phrase for it, because they don't communicate with the CGM. And I can tell you that Tandem is a pump company, and they're officially approved for type 2. Then there is the Omnipod 5, which is a patch pump approved for type 2s. And the Medtronic 780G, I can't remember if that's approved for type 2s. And then there's the Sequel pump and the iLet pump. And we have 5 on the market. And I can tell you that speaking to the representatives for these pump companies, they say 25 to 30% of their customers are type 2. So it only makes sense that if you need insulin, you should be getting one of these systems versus one where you have to make your own decisions. Yeah. That's just the old days. And I don't think it adds much to the cost at all. And I would urge you all to look at each one, the features of each one, and decide which one fits your lifestyle. And on our website, we did a incredible video called Speed Dating with your automatic insulin delivery system. And Jeremy was dating each one of these, and each pump was a woman, almost, till we got to the twist. And it's funny and it's interesting, but we give real data on some of the characteristics of each pump. And so I think that if you're a type 2 on insulin, whether you're on a GLP-1 or not, or other drugs, SGLT2 for protection of your kidneys, for example, you should look into these.
Mm-hmm. And I would say, just to clarify for the type 2s who are on insulin, a lot of type 2s, if they're just on basal insulin, so 1 insulin shot a day, then switching over to the pump may make their life a little more complicated. If you're doing well on just 1 insulin injection a day of basal insulin, it's probably fine just to stay there.
Yeah.
But if you're injecting multiple times a day for every meal, it can really make your life easier. And that's kind of what it's about. I think it's not that a pump is, necessarily, it's not that you can't control your diabetes by being on insulin injections. You can. It's just harder.
Yeah.
So.
And these systems, they have settings that you would use even if you're just on multiple daily injections, like how much insulin per gram of carbs, or your correction factor, or the basal rate, which would be your basal dose of your long-acting insulin. So the settings aren't that complicated. And your job as a person using these pumps is to obviously know how to fill them up and change them, but to enter the carbs that you're eating, or enter the amount of insulin that you need for a meal. And so it really takes away all the injections, except when you put in the insertion line every 3 days.
It's nice. You don't have to bring all that stuff with you everywhere. If you're going out to dinner or something, you can everything's on you, and it makes life easier for sure.
And there's lots of good data too. There's so many studies looking at these systems in type 2. So I would say if you're on, and thank you for mentioning that, multiple daily injections, it might be a system that's going to make your life easier and better control, less hypoglycemia too.
Yeah, safer for sure.
Safer.
Yeah, absolutely. Okay, I want to change subjects here a little bit and talk about MASH. So this is liver disease that is associated with type 2 diabetes. There's questions about what is it? How serious is it? How do you know you have it? Lots of questions here. Do you want to tell us what it is, Steve?
Well, I'll start off.
Okay.
You know that as well as I do. Well, basically, MASH stands for metabolic associated steatohepatitis. And what that means is, let me take one step back. I mentioned briefly earlier that people with type 2 diabetes have metabolic syndrome. They have high cholesterol, they have high blood pressure, they have weight problems, and probably there is inflammation. And that sets a very dangerous platform for these other medical problems: heart disease, kidney disease, and liver disease. So what happens when you get overweight, the cells in your liver get fat, and that causes inflammation. And over time, that inflammation turns to fibrosis. And that's what we call cirrhosis, or MASH is the beginning of some fibrosis. End stage fibrosis is cirrhosis. And when you get cirrhosis in your liver, you need a new liver, or you pass away, or you need a transplant. And so MASH happens to be one of the most underdiagnosed, serious medical conditions we have. I should mention that Jeremy and I did a short video on MASH. You can check it out on our website. And we opened with the MASH TV series with the theme song, just to get you in the mood. But what can you add to what I just said?
Yeah, I would say, fibrosis is just to clarify the medical word for scarring. So that's basically what happens is over time, the liver, after it gets inflamed, it just gets scarred down and it stops working. So, MASH, how do you know you have it? That was one of the questions. Yeah. The actual diagnosis can be kind of complicated, but what I'll tell you is the screening test is really simple. It's a simple blood test. Your doctor just has to order a few blood tests that they kind of put together and make a calculation and decide if you're what your risk is for MASH, and then it goes from there. Once you get that, you may get other tests that involve kind of fancy ultrasounds, referral to a GI specialist, et cetera. But that initial test is really just a blood test. And that's how we diagnose it.
Yeah, it's the FIB4, and it's the liver function tests, which are on everybody's complete metabolic panel that you always get. Platelets, which is more if they're checking your blood count, and then your age.
Yeah.
And it's a simple calculation. And in fact, some hospitals will calculate it for the doctor.
Yeah. It's
sitting right there, like your A1C. If it's above a certain level, then you go to the next step. And that could be what we call a fiber scan, like an ultrasound, and a bunch of other tests. We don't get into the details, but you want to catch this early. And some people present with just liver function tests being elevated, and that's kind of a red flag goes off for the caregiver to maybe go a little deeper. And you should all know your FIB4 value.
Yeah,
I think so.
You should be asking for it if you haven't heard about it before.
Yeah, if you have type 2, you should ask, am I at risk, or do I have fatty liver? And they're going to go, oh, scratch their head, pretend like they know what they're talking about, look it up in a textbook, and then figure it out for you. So it's extremely common, and it's a very serious condition.
It is, but luckily there are some ways to prevent it or slow it down.
Yes.
Certainly weight loss is really effective. That's probably the biggest and not that it's easy, but the easiest thing you can do to kind of decrease your risk of MASH, or if you have kind of early signs to improve. And in the early stages, you can actually reverse some of this diagnosis. Once it gets down to the scarring, then you can't reverse it. But if you catch it early, you can. So weight loss is really effective. The GLP-1 medications, here they come up again. I mean, truly, they're just all over the place with the benefits. But those GLP-1 medications are beneficial. They also cause significant amount of weight loss. You're not just losing weight, in the abdomen or wherever else. You're losing the fat in the liver. And so that's really helpful. One of our other medications that I mentioned for type 2 diabetes, the pioglitazone or Actos, that medication has been shown to be helpful in MASH. And there are actually hundreds of medications that are being studied and probably will be approved over the next several years.
Yeah, and one that was just recently approved called Resdifra.
Oh, I'm glad you said that.
Yeah, I practiced that. And that is a drug approved last year for the treatment of MASH. So if you have MASH, I mean, sure, you got to lose weight. GLP-1s will help you lose weight. They may have mechanisms beyond weight loss, but nonetheless, it's been seen with all the GLP-1s. But Ozempic, or I should say Wegovy, gets credit for getting the official FDA indication. Then you have Resdifra, and you should not be drinking alcohol. So I hope Dr. Pettis doesn't get MASH, because he's going to be in big trouble. And he's not here, so I can make fun of him.
All right. Yeah. Okay. Along the lines of kind of complications associated with type 2 diabetes, let's talk about kidney disease. This question says, my doctor says I have chronic kidney disease. How do I prevent dialysis or needing a transplant?
Yeah, I think that's a fear for everybody with diabetes, including my own. And chronic kidney disease also is a serious problem. It probably is brought to light more than fatty liver these days. And anybody can get chronic kidney disease, but people with type 1 and type 2 are at risk, typically from elevated blood sugars through the years or high blood pressure and maybe some other things. But one good thing, Tricia, we should take turns going through the pillars of therapy. And the kidney doctors call it pillars. And I'm not sure why, but it sounds good. Like, what are the basic things to prevent uh, uh, chronic or kidney disease in people with any type of diabetes?
Yeah. Well, I mean, first and foremost is blood sugar control, right? So we know that over the long term, having high blood sugars can lead to chronic kidney disease and worsening of chronic kidney disease. I think we're always kind of working on that because we're in the diabetes field. Y'all are thinking about diabetes all the time. But I think Steve's asking about kind of the other things that we can do on top of that. So, number one is blood pressure control. So, the most common causes of people going on dialysis is both diabetes and high blood pressure. So, really making sure that that blood pressure is under controlled is key to preventing chronic kidney disease. Now, if you have diabetes, it turns out that there are some blood pressure medicines that are better than others. So, I saw a question in here about atenolol, which is a blood pressure medicine. One of the blood pressure medicines, the class of medicines, is called ACE inhibitors or ARBs. ARBs. So those classes of medications tend to prevent kidney disease better in people with diabetes.
Yeah, and perfectly said. And I think I would add on there that anybody with high blood pressure needs to get their own blood pressure cuff, because there are no symptoms of blood pressure, especially in the range of where it can cause damage over time. And the once or twice measurements when you go to the doctors, they're not that accurate. You're rushing around, you're late, and the nurse may measure it really quickly and not get an accurate value. So get your own cuff, make sure it's accurate, and measure at home. Not a ton, but maybe once or twice a week. And if it's always normal, maybe once or twice a month. You don't have to spend a lot of time, but you need to get your own cuff for sure.
Nowadays we keep going back to these GLP-1s and SGLT2s, but truly they are really showing impressive data in terms of how they're preventing the progression of diabetic kidney disease. So the SGLT2s, everyone with kidney disease, unless you have a contraindication to these medicines, you really should be on an SGLT2 inhibitor.
Yep.
So
we should name those.
Yeah.
So Jardiance, Farxiga, Invokana, Zynquista, Impifa. There's a whole bunch of them, but they came to the market. They don't lower the blood sugar that much. They're approved for type 2s right now. However, I haven't had one patient with type 1 denied for one of these medications if they have evidence of kidney disease.
Yeah.
Because they are extremely effective. And as we mentioned a little while ago, Ozempic got the approval for reducing the progression of kidney disease. So when you talk about these pillars, I've heard kidney doctors say you got to throw the whole book at the patient. You don't want them to go on dialysis.
Yeah.
And I agree with that. So obviously, glucose blood pressure control is key. And if you have high blood pressure, get on one of these ACE inhibitors or ARBs, and you might need other blood pressure pills to get you to goal. And then SGLT2 inhibitors, GLP-1 receptor agonists, and there's one more.
The finerenone.
Finerenone. Oh my God. That's the latest.
Yes. Tell us about that, Steve.
Well, you know what? You ready for this? I'm going to impress you. All these big names is MRA inhibitor. It's a mineralocorticoid receptor antagonist. And they work in a different manner, but they have clearly been shown to reduce the progression of kidney disease. And you could use them with everything else we mentioned. And there was just a big announcement that it's already been approved for type 2 diabetes and kidney disease, that they had really good data in folks with type 1. Now, I think we should also talk about what tests people should know about, just like we did with MASH.
Yeah, that's a great question. So every year at a minimum, your doctor should be testing you for chronic kidney disease. And, once you have chronic kidney disease, they may do other tests and test you more frequently. But the initial tests that you want to ask for are just your basic metabolic panel that is going to have your creatinine and your estimated GFR. So these are, big mouthfuls of words, but there are two tests that we look at for monitoring kidney disease. There's another test that we're using more nowadays called cystatin C. That is another test that sometimes we use to check for kidney disease in patients who may be much older and very lean and kind of more frail. That's one of the populations that we kind of use that test. And then we also check for microalbumin, or a small amount of protein in a urine test. So your doctor should be having you give a urine sample, and we check for whether your kidneys are spilling protein into the urine, because that's one of the earliest signs of kidney disease and diabetes.
Yeah, if I had to pick one test, it would be the microalbumin to creatinine ratio. It's a simple urine test. You don't have to be fasting, and it is highly correlated with chronic kidney disease.
Yeah.
And then they would follow that over time. So it's something that you should ask your doctor for, because a lot of times they won't measure it. It's just a urine test. You don't even have to get a blood test to do the calculation. So, and we've done programs on that on the TCOYD website, the microalbumin to creatinine ratio, and then the estimated GFR is the other really important one. But they're all very important, but those two are the most important. And there are graphs that doctors use to see if you're at minimal risk, mild risk, or much more greater risk. And they might tell you yours is completely normal, so you don't need to test for a year.
Yeah.
But you want to keep an eye on that, because if it starts to creep up towards the abnormal level, and I'd like to treat people early, not wait till it gets really high, that's when you're going to be focusing in on all the pillars we talked about, including adding on SGLT2 inhibitor or a GLP-1.
And another important question for your healthcare provider is, when do I need to see a kidney doctor, a nephrologist? Because we have very clear guidelines, and the American Diabetes Association gives us kind of a chart where we can look at. And when the kidney disease gets to a certain point, it's important to get plugged in with a kidney doctor, not because you're going on dialysis the next week, but just because they're really the experts in continuing to kind of hone in on these pillars that Steve was talking about.
Yeah, and they'll measure some other sophisticated lab values,
Yeah.
your phosphate and things like that. And they'll look for other things that may have messed up your kidney function.
Yeah. And then the last thing I'll say on the kidney function is that the SGLT2 inhibitors are so good at preventing the progression of diabetic kidney disease that you should be on them even if your blood sugar control is perfect. So that's what our guidelines tell us. Even if your A1C is below where you want it, blood sugars look great, you should still take that SGLT2 inhibitor, because that medication is working all by itself, regardless of the blood sugars, to prevent the kidney disease.
Think about this. They take people with prediabetes, they put them on GLP-1 and the SGLT2. The world would be a better place. That is
That's
for
what
sure.
I said. Put them in the water.
And remember, these SGLT2s, they're just pills. You take them in the morning. Some people notice a little more frequent urination in the morning. That typically goes away. And there's a few other side effects, but they are rare. It's one of the most well-tolerated class of agents. And it does so many good things. It's impressive.
It really is. And so easy to take.
Yeah.
Really. Yeah. Okay. I think this might be our last question, but I think it's an important one. It says, should I get a dietitian? And if so, how do I find the right one? And this is a really complicated question. I think that, nutrition and diet are so important, whether you have diabetes or not, truthfully, but in people with diabetes. But I also think that there's a lot of fear around seeing a dietitian, and maybe worry about them kind of telling you what to do, and it's hard to make change, and you may not necessarily be ready for change. And so, I do think it's important to understand that there is no perfect diet for diabetes, really. Um, I really believe that everything can be done in moderation. And, it's very hard, especially culturally, to cut a complete, rice or tortillas or, something complete,
Matzo
bread,
balls,
whatever it is. Yes.
they got a lot of carbs.
Completely out of your diet. So I think finding a dietitian is a great idea. I think that, making sure that you have someone that's working with you and and being open to the dietitian about the types of foods that are important to you, either with your family or culturally, so that they can really work with you to come up with something reasonable.
Yeah, I mean, well said, Tricia. I mean, it's not, rocket science. And I think most people I talk to know about what to eat and what's healthy, what's not healthy, but guidance is important.
Yeah.
And doing it with someone. And I would say that we have some really excellent lectures on our website. Valencia,
Yep,
Adriana
Adriana.
Valencia, and also Jenny Luna and Janice Baker. And, it just depends on what you're looking for. And I think, we all need to become experts in what we eat. And it's just common sense. And you try to find foods that you like. And that's something that, if you don't like cottage cheese, don't go for a scoop of cottage cheese and rye crisp crackers, which was on my list when I got diabetes.
Right. I mean, a lot of dietitians will tell you that you can eat a lot of the foods you love. It's more about portions, and making sure that things are kind of balanced rather than restriction.
Yeah, you've heard that phrase, we are what we eat. When you have diabetes, we are how much we eat.
Yeah.
So that's really, it's all about portion control.
All right. Well, I think we're out of time. That went by fast.
Yeah. That was a great session.
Yeah. So many great questions, really important questions. And thank you all so much for being here today.
Yeah. Thank everyone. Make sure that you send us any questions on our blog. Check out our website. And for all the things you get through social media, you like, subscribe, and watch our podcasts on your favorite platform.
Bye, everyone.
Okay, thanks, producer. Goodbye, everybody.